Magandang hapon po sa lahat. Start na ba tayo? Isang malugod po na pagbati mula sa Coalition for People's Right to Health para dito sa ating ika-anim yata na Raise the Bar series na ang title po sa ngayon ay Caring for Our Physicians and Caring for Our Healthcare System. Para po dun sa mga ngayon lamang ulit makakapakinig, ang ating pong Raise the Bar series ng Coalition for People's Right to Health ay naglalayo na maglinaw ng mga usapin na kinaharap natin ngayong nagkaroon tayo ng COVID pandemic. At dahil dito ay gusto natin sa ating mga karanasan ay gusto nating maitaas at improve pa ang ating healthcare system. Kaya ang naging title nga niya ay Raise the Bar for Our Healthcare System. So, ngayon ang ating pong tatalakayin ay ang tungkol naman sa mga health personnel o sa ating health human resources at paano natin mas mapauunlad ang pagkalinga natin sa ating mga kumikilos sa ating sistemang pangkalusugan. Particular ngayong hapon, tatampok natin ang kalagayan ng ating mga doktor, ng ating mga physicians. Tampok na usapin sa ngayon, pagkatapos ng crisis na dulot ng COVID pandemic, ay ang crisis din sa ating healthcare system. Ayon nga sa Vice President ng Private Hospitals Association, hindi nila ngayon masabi ang totoo o ang aktwal na bilang ng mga ospital na full capacity na sa mga COVID patients. Pero sa mga balita nitong nakaraang ilang araw, ang Makati Medical Center, St. Luke's Medical Center, Quezon City, and Bonifacio Global City, ganun din ang Bogo City Hospital, nagdeklara na puno na ang kanilang capacity para sa mga COVID patients at hindi na sila makatatanggap. Ang ating Philippine General Hospital, ganun din ay halos puno na daw ang kanilang mga allocated na mga kama, wards at saka ICU beds para sa COVID patients. Isang dahilan dito ay ang pagkakaroon din ng malaking epekto o tama sa mga hospital workers na tinamaan ng sakit na COVID. As of July 5, ang idineklara ng ating Department of Health na mga hospital workers na nagka-COVID o positibo ay 3,513. At April pa nga lang, alam natin, ang WHO ay nagpahayag na ng kanilang concern dahil sa malaking bilang ng mga health personnel na tinatamaan ng COVID virus dito sa ating bansa. Doon sa total na 3,000, mahigit 34 na po na mga doktor at iba pang personnel ang namatay. Totoo na mayroong mga 2,643 na nakarecover. Pero doon sa total na 3,000 ay halos mahigit 25% o mahigit na 875 actually na mga doktor ang apektado o nagkasakit ng COVID. Nito laang July 10 ay isa na naman sa ating mga colleagues ang pumanaw dahil sa COVID-19. Kaya tayo ay nagpapaabot ng ating heartfelt sympathy and condolences sa family and friends ni Dr. Gina Maria Regina Uy Alegado na pumanaw noong July 10 nung Friday. Isang malungkot na pangyayari ang ating dinaranas ngayon dulot nitong pandemya. At ang mga kasama nga sa mga nasa frontline ay ang ating mga doktor na sila nating pagtutuunan ngayon ng pansin. Ang ating mga guest speakers ngayong hapon ay mula sa iba't ibang fields ng ating sektor. So, ang isa ay mula sa Provincial Health Office ng Dinagat Island at ang isa naman ay educator na nagtuturo sa St. Luke's Medical Center at ang ikatlo ay isa ring doktor na nasa larangan naman ng legislative advocacy at iba pang mga advocacy for the people's right to health. So, I'm proud to say ng ating pong mga speakers ngayon ay mga graduates ng ng UP College of Medicine at ng Philippine Science High School. Si Dr. Jillian Francise Lee, ang una nating speaker, batch 2016 ng UP College of Medicine. Siya ay isa sa ating mga bagong heroines na sumama sa Doctors to the Barrios program noong mismong pagka-graduate niya. At siya ay nagsilbing Municipal Health Officer sa province ng Dinagat Islands, 3 taon kasama ng DTTB program. At nitong January 2020, just in time for COVID, siya ay naging Provincial Health Officer. So, pakinggan natin ngayong hapon ang pagbabahagi ng isa sa ating mga magigiting na frontliners, si Dr. Jillian Francise Lee. Jillian?
Afternoon, shucks. Sorry, ngayon pa lang pala nag-open yung mic. Good afternoon po, Doc Yan. Good afternoon po sa lahat ng ating listeners today. So, salamat po sa introduction. First and foremost, gusto ko lang din na i-emphasize na kahit na ang ating topic for today ay caring for our physicians and caring for our health system, gusto ko lang ipaalala na ang ating health system ay hindi lang din limitado sa ating mga doktor. Napaka-importante rin ang role ng ating mga nurses, ng ating midwives, ng ating medtechs, yung mga auxiliary staff kung wala sila, hindi din magfo-function ang mga healthcare facilities natin, utility, drivers, responders, and sa community, lalong-lalo na sa mga panahon na ito, ang ating volunteer community health workers, ang ating barangay health workers. Pero for the purposes of this discussion, pag-usapan muna natin kung ano ang kalagayan ng ating mga physicians sa community ngayon. So later on, probably itatackle ng ibang speakers ang mga physicians sa hospital, physicians sa academy, physicians sa ibang larangan. Pero I'd like to focus more on community physicians working in community medicine. Una dahil doon ako galing at yan ang aking trabaho ngayon sa Provincial Health Office, and ang pinaka-battle na fina-face natin ngayon ay wala na sa hospitals, na sa communities. Karamihan kasi ng coverage in general pagdating sa response sa COVID-19 in particular, and when talking about the health system in general, ay focused pa rin sa hospitals, focused sa specialist care, focused sa facility-based care, sa inpatient care, na nakakaligtaan ang importance ng preventive care, ng community medicine, ng public health. Ngayon, tulad ng sinabi ni Doc Yayan kanina, alam na natin na madaming hospitals ang now-overwhelmed. Sa Metro Manila, sa Metro Cebu, madaming hospitals na ang nagde-declare na full capacity na sila. Hindi na nila kayang mag-accommodate pa ng patients. Hindi na nila kayang mag-accommodate ng COVID-19 patients, and hindi lang naman COVID-19 ang problema natin ngayon. Hindi naman nawawala ang ibang sakit dahil lang may COVID-19. Ang battle natin ngayon ay nasa ating mga communities. Ang ating communities ang ating mga frontlines. Kumbaga, ang gusto din kasi sana natin ay mabigyan ng importance ng ating Department of Health, ng ating local government units, and ng ating national government ang pag-focus sa prevention and sa containment. Unfortunately, isa sa pinaka main challenges ng mga physicians sa communities ay kadalasan hindi nakikita ng ating local leaders yung importance nito. Very evident ito pag titingnan lang ang ating mga numbers kasi sobrang layo ng current na status ng parang ating doctor to patient ratio, physician to patient ratio sa community kaysa sa nire-recommend. Marami pa rin, over 200 pa rin na munisipyo sa Pilipinas ang walang doktor, and ang iba kahit na merong doktor, sobrang hindi conducive sa tamang patient care ang numbers na kailangan nila i-face. Nung nasa DTTB program po ako, may mga kaklase po ako na mag-isa lang silang doktor sa isang munisipyo na 50,000 people, 100,000 people. And given na ganyan ang situation nila noon, nung wala pang COVID at sila ay na-overwhelmed sa health concerns ng community, you can only imagine kung gaano ka na-exacerbate ang kanilang problems ngayon na hindi lang nila kailangang i-handle ang mga routine health programs and ang ordinary health services ng kanilang mga rural health units, kasama na rin ang pag-manage ng kanilang health human resources, kasama na rin ang pag-manage ng kanilang budget. Kailangan din nilang magtrabaho para sa prevention and sa control ng COVID-19. We all know na very limited din ang ating testing capacity. Hindi pa natin naabot ang recommended na national daily testing capacity, and karamihan pa rin ng ating testing centers ay concentrated sa mga urban areas. So, pagdating sa mga communities, ang mga physicians talaga, kailangan nilang mag-focus sa containment, kailangan nilang mag-focus sa pag-isolate ng anyone na pwedeng maging carrier ng COVID-19. Kasi most of our rural communities, wala silang kakayahang mag-manage ng outbreak. For instance kami, dito sa probinsya sa Dinagat Islands, wala pa kaming confirmed cases sa COVID-19. We only have 13 doctors and we only have 3 infirmaries. Hindi man lang sila registered bilang district hospitals kasi hindi nila nami-meet ang physician to facility na requirement. Hindi nila nami-meet ang standards para sa health facilities. So ang point ko lang ay sobrang limited ng capacity namin, and marami ring mga provinces and maraming towns in rural areas, especially sa ating mga isolated na isla, sa ating mga isolated na bundok na ganito ang kanilang situation. Mag-isa lang silang doktor, wala silang reliever, wala silang testing capability. Kung may pagre-referan sila, medyo malayo-layo ito at hindi mabilis na bumabalik ang results. And aside from having to manage COVID-19 with limited testing capacity, limited isolation facilities, and limited personnel, kailangan din nilang mag-handle ng other concerns. Sanitation, tuberculosis, malnutrition, non-communicable diseases. Hindi naman nawawala ang mga taong nag-high blood at ang mga taong nagsa-stroke dahil lang may COVID-19. And lalong napapakita, parang lalong na-emphasize ang mga deficiencies ng ating healthcare system ngayon na may pandemic. Kasi dahil sa limitations sa movement, nababawasan or rather nagiging mas inconvenient para sa mga pasyente to travel to tertiary centers para mag-access ng diagnostic facilities, para mag-access ng gamot. Lalong nakikita kung gaano ka-limited yung care na kayang i-provide sa community, especially kung ang mga local governments ay hindi nagbibigay ng importance sa healthcare. Ang kalusugan kasi ay devolved sa ating mga national government. So ang nagbabudget sa ating mga rural health units, sa ating mga district hospitals ay nasa ating mga provincial governments. Wala sila sa national na Department of Health. And sad to say, except probably most of you already know this din, na ang mga hindi karamihan, pero meron, and probably sila is isang significant number ng population ng ating mga local government units ay hindi nila nakikita ang importance ng pag-provide ng healthcare, or ang tingin din nila sa healthcare ay bilang income generating, which considering their populations ay parang kung ganun ang tingin mo sa health, hindi mo kayang mag-provide ng accessible care or care na affordable sa karamihan ng populations mo. But more specifically din sa, sorry, medyo ano, I think nawala ako sa ano. So yung general na kawalan din ng investment sa health ay, yun nga, as I said, parang mas napapakita na, mas na-emphasize yung challenges nito sa mga physicians sa community sa time na ito. Kung ang government ninyo ay nag-choose to spend on something else kaysa sa nag-inventory or rather nag-stock ng personal protective equipment, kaya madaming nakukulangan ng protection, kaya nung unang mga months ng COVID outbreak and hanggang ngayon, because of the nature of their profession and sa kakulangan ng protection, madaming health workers na na-expose sa COVID-19, marami sa kanila ang pumanaw dahil sa COVID-19, and ang problem din specifically sa communities dahil limited parang nationwide ng mga personal protective equipment. Ang naging focus na padalhan ng personal protective equipment ang mga hospitals. Hindi sa sinasabi natin hindi sila nangangailangan ng personal protective equipment, pero nakakaligtaan din kadalasan ng ating mga government units na bigyan din, aside from government hospitals, pati ang mga physicians and ang mga other health workers sa ating communities, kasi especially now na madaming nagsiuwian sa mga probinsya na parang sa process ng kanilang pag-uwi ay nagdala ng COVID-19 sa kanilang mga probinsya, at sila ay binabantayan ng ating mga community physicians and ng ating mga nurses sa ating communities. Very important ang pag-preserve ng health ng ating community health practitioners, hindi lang para masiguradong hindi sila magkasakit. Pero din kung magkasakit sila, kadalasan wala din silang karelyebo, wala din silang kapalit, walang ibang taong gagawa ng trabaho nila para sa kanila kung sila ay mawala dahil sa COVID-19. Going back then sa parang LG prioritization ng health, kadalasan din hindi din kadalasan, pero madalas na nangyayari na gumagawa ng decisions ang ating authorities on health measures or on measures na nag-a-affect ng public health, which refers to most interventions ngayon, especially nga dahil tayo na sa pandemic, na walang consultation sa mga stakeholders, na wala ding consultation or pwedeng hindi nabibigyan ng importansya ang advice ng local na public health workers, ng ating local public health physicians, ng kanilang mga municipal health officers or provincial health officers. So dito sa province namin, sinasabi ko lang na parang napakaswerte namin kasi in general ang aming mga public officials ay nakikinig sa aming mga payo. Nung nag-advise kami nung March na magsarado ng borders, in-explain sa kanila yung importance ng containment, na hindi natin kayang mag-cope sa isang outbreak ng COVID-19. Naintindihan naman nila yung need na i-curtail yung movement. Pero sa ibang LGUs na mas hindi masyadong parang striking sa kanila yung impact, rather yung positive effects na pwedeng makakuha sa pag-close and pag-isolate ng mga tao sa health as opposed sa possible na economic na repercussions, hindi ito nangyayari. Especially nung ang National IATF ay nag-a-advise na mag-reopen na, nagbababa sila ng mga recommended na parang quarantine classifications, nahihirapan din ang mga health workers na i-emphasize sa public and na i-emphasize din sa kanilang local leaders na hindi pa natin to nakokontrol. Kailangan pa nating mag-work sa containment, hindi lang dahil tayo ay nag-shift from ECQ to GCQ or from GCQ to MGCQ, ay ibig sabihin nun na nakokontrol na nananalo na tayo sa COVID-19. But as you can imagine, para sa tao sa ground, napakahirap na i-convince ang mga tao nun kung ang mismong national government mo ay nagsasabi na nananalo na tayo. Napakahirap na magsabi na kailangan pa rin nating mag-ingat kung ang national government mo ay nagbibigay ng directives na okay, magbukas na tayo. And marami ding national directives na binababa lang din na walang consultation sa ating mga local government units tulad ng hatid, ang tawag nila dito, yung napapagkamalan siyang balik probinsya, pero yung totoong name niya ay hatid tulong na program na kung saan na nag-repatriate ng mga locally stranded individuals and ng returning overseas Filipinos, pero sa kanilang parang mandate, hindi na sila nagre-require ng acceptance galing sa mga local government units to prevent din na tumatagal sila sa places kung saan hindi na sila wala na silang trabaho, wala na silang tirahan, hindi na sila nakakakuha ng tulong. Pero yung nagiging kapalit nun, nababurden ang ating mga local government units at ang ating mga physicians and nurses and community health workers sa pag-track ng mga taong papasok, sa pag-ensure na sila ay isolated, sa pagbantay sa kanila sa pagbantay sa kanila to ensure na nag-remain sila na asymptomatic. Pagdating din sa compensation sa ating mga community health workers, nagkakaroon din tayo ng problem kasi sa Doctors Labarios program kung saan ako nagtrabaho before, under siya sa national government. So, ang sahod ay katumbas ng national government salary, but for many municipal health officers, rural health physicians, and other nurses and midwives, hindi na i-implement ang Magna Carta for Public Health Workers na nag-require na lahat ay tawag natin dito nagki-keep sa national salary grade standards. So usually kung sino yung mas may hirap na local governments, ang mga 5th class municipalities, 4th class municipalities, na ang nabibigay lang nila na sahod sa kanilang mga health workers ay katumbas din sa level ng nabibigay nila sa ibang employees ng kanilang municipality. Isa din to sa mga factors kung bakit maraming health workers ang hindi pumipili na mag-work sa community kasi katiting lang ang sahod na nakukuha nila and kadalasan limited lang din ang slots para sa regular employees, sa permanently employed na health workers. Usually maraming nagwo-work na nurses or midwives or minsan physicians din na job order lang sila, contractual sila. And wala silang nakukuhang adequate na compensation para sa trabaho na ginagawa nila. And at this point in time na rin sa ating kasi may parang fund pa to allocate for relief, for hazard pay, pero ngayon medyo 5 months into the pandemic na tayo, and hindi siya nagsho-show ng pag-slow down anytime soon. And na-exhaust na rin ang resources ng ating local government units sa pag-provide ng PPE, sa pag-provide ng compensation sa ating mga physicians. And lalo ding na-exhaust ang ating mga healthcare workers na aside from having to manage COVID-19, sa kanila pa din ang vaccination, ang maternal care, ang pag-establish ng emergency referral system, sa sanitation. Napakahirap niya kahit sa mga long time na health professionals, and I imagine mas mahirap pa siya lalong-lalo na sa mga bagong pasok na doctors to the barrios. So, ang ano din natin ay kung ang mga physicians natin ay ganito ang fine-face na problems, lalong-lalo na ang ibang health workers, ang ating mga nurses, ang ating mga midwives, ang ating mga barangay health workers na volunteers nga lang sila, wala nga silang natatanggap na sahod, mas hindi sila napapakinggan compared sa physicians, minsan mas konti pa ang protection na allocated sa kanila. So, thank you, Doc. Sorry, I think nag-over na ako sa aking time. Thank you very much, Doc Yayen. Kayo na ulit, I think.
Sige. Salamat, Jillian. Una, sa paglilinaw mo ng mahalagang papel ng ating health team sa mga pamayanan, kasama ang ating mga nurses, midwives, at saka mga barangay health workers at community leaders. Ganun din doon sa pagbigay ng focus sa isang matalas nakakaligtaan na gawain natin sa komunidad, yung containment nga and prevention, at paglinaw na sa ating kalagayan ngayon, ang ating mga pamayanan at ang mga nasa community ang nasa frontline, no? Kasi palagi nga sinasabi yan ng mga taga-ospital, kami actually ay parang ano lang, no? Backup o last resort na
Last resort.
No? Last resort na sa ating mga nagkakasakit ng COVID. At ang talagang nasa frontline ay kayo na mga nasa community. Ayan. Salamat din sa paglalarawan mo ng kalagayan ng ating mga doktor at ang ating healthcare services sa mga underserved, tinatawag na areas ng ating bansa. Yung mga geographically isolated and disadvantaged areas o yung mga 4th and 5th class nga na municipalities at yung pangangailangan din nila bilang nasa mga frontline. Akala kasi nila porke nasa isla kayo ay protektado sila, hindi sila abutin ng COVID. Ganyan yung karaniwang naiisip na yung mga nasa malalayong lugar dito sa ating bansa
Safe.
ay malayo rin sa COVID. So, kasama rin din sa nilinaw ni Jillian yung persistent na unequal distribution ng ating mga doktor na kung ilan pa, marigit 200 na mga municipalities ang walang doktor mismo sa kanilang lugar. At kasama dito yung problema ng pagpa-prioritize ng healthcare system sa ating primary level o yung primary healthcare, no? Ganun din na ibahagi niya yung mga usapin para sa kapakanan ng ating mga doktor at iba pang health workers, no? Yung hindi pagpapatupad ng ating Magna Carta, provisions ng Magna Carta for public health workers kung saan nililinaw na merong standard salaries dapat na sinusunod para sa ating mga public healthcare workers. So, iyan. Salamat ulit, Jillian, para dun sa mga katanungan para kay Doc Jillian mamaya after nung ating mga speakers. Sige, salamat.
Alright, thank you. Alright, salamat. Thank you very much.
Okay. Ang sunod nating tagapagsalita ay isang isa ring membro ng ating community medicine practitioners and a strong advocate of community health work and primary health care. Siya ay si Dr. Malaya Santos, isa doctor at saka masters in public health at practitioner din ng Dermatological Society, member ng Philippine Dermatological Society. Siya ngayon ang head ng Medical Education Unit ng St. Luke's Medical Center, College of Medicine. at isang associate professor for microbiology. Siya rin ay miyembro ng leprosy subgroup ng Philippine Dermatological Society at a chapter ng Delta Omega Honorary Society for Public Health. At para dun sa mga gusto pang magbasa ng kanyang mga pahayag, siya isang columnist, regular ng Health and Lifestyle magazine. Ang kanyang column ay A Different Drum. Member din siya ng National Institutes of Health Skin Study Group. And I'm also proud to say na siya, si Dr. Maya Santos, is an awardee of the Alumni Society of the Philippine Science High School, Gawad Lagablab. So pakinggan natin po ngayon si Dr. Maya Santos. Thanks, Maya.
Good afternoon po, Dr. Yayen. Maraming salamat po for this invitation. Pwede po ba akong mag-share ng screen? Sandali po ha. I will try to navigate this new system. Share screen. Nakikita niyo po ba? Okay. Yan, slideshow. I was asked, I hope I understood po the instructions. I was asked to talk about the educational perspective and the role of the academe in preparing the workforce, the health workforce, to take their place in the front lines at all levels of the healthcare system. Naririnig niyo po ba ako? Ang hirap ng walang kausap sa webinars. But I hope that you can hear me. So I normally speak to students. So ito pong aking first slide. I recycled it from another talk. At ginamit ko pong title ay Silver Linings and the Redefining Medical Education and Strengthening Student Support During the Time of COVID. Sa mga mahilig po sa Marvel, this shows the epic final battle of the Marvel superheroes. And ang kasunod po na scene nito is where they pick up the pieces and move forward. Kaya lang po sa ating kasalukuyang sitwasyon, hindi po natin alam exactly kung ano yung, paano tayo mag-move forward kasi hindi pa naman po talaga natatapos yung pandemya. And I think it is this high degree of uncertainty that is really so difficult for all of us in terms of adapting to the new normal and for us in the academe, how to teach and for the students how to study. So meron po akong ikukwento na isang incident nung bago po magsara just before we had ECQ last March. Dami po naming meeting, sunod-sunod, meeting dito, meeting doon. And then I sat down together with one of my other colleagues and sabi ko, if in 2 weeks our health system gets overwhelmed, and all of this collapses, will any of this that we are planning make any difference? At ang sabi naman po sa akin nung syempre drama-drama siya ng konti, ako din emot-emot ng konti. Sabi niya, then if that happens, then we will go down fighting, sabi niya ganyan. And 3-4 months after, I still feel like we're still in a battle, but all the same, we need to be able to find our way and be able to continue our mandate, in our side as educators of future health professionals. Health professionals, naku, maingay. Okay, so I have no conflicts of interest to declare. I will draw upon my experience as an educator since 2007. My experience working in community health since the time that I was a student and the time that I worked under the Provincial Health Office of Palawan, another island province circa 1996 to 1997 after I graduated. Later on, as I joined other projects together with the DOH, specifically for leprosy after I did my residency in dermatology. And now, as an educator, trying to integrate all of these principles, ethics, community medicine, primary healthcare, into the curriculum at all the different levels. So, I will use any platform to be able to explain why public health is so important in education, not just in practice, but also in education, and even so much more now that we are in a pandemic situation. But I realize that maybe this is, in this case, I am speaking to the choir kasi hindi ko na po kayo kailangan i-convince. So what might be considered the silver lining in this situation is that we are now all required to revisit epidemiologic principles. Ano nga ba ulit yung definition ng epidemic, outbreak, cluster, pandemic, ano ba yung epidemic curve na yan? What does it mean to flatten the curve? What is herd immunity? These used to be concepts that were just maybe relegated to the back of our minds and memorized because we needed to pass the boards. But in a lot of the clinical practices, these were no longer concepts that were really in the forefront of our minds. Well, guess what? Now we have to revisit and remember. So when I was studying public health in 2003, the concept of emerging infectious disease was a fairly new concept. And when I started teaching microbiology in 2007, inintroduce ko po siya sa course, microbiology course at St. Luke's College of Medicine. And hindi ko alam kung pinapansin ako ng mga estudyante, but I would talk about the factors in emergence. And little by little, I would also do my best to update everyone on current emerging infectious diseases from the time of SARS to MERS to Ebola. And really, when we look at these different factors, we will actually see that this was a pandemic that was waiting to happen. So unfortunately, the Philippines was not prepared for this pandemic, and generally speaking, nor was the world or the global health system. So there were so many more things that should have been put in place so that we could respond adequately to this pandemic. And hopefully, we will learn lessons because this is something that was waiting to happen, and also this is something that will not be the last time that we will face such a an emerging infectious disease. And so again, we need to prepare to address what we are going through now and address future challenges that will come. So this is a slide that shows the globalization of commerce, of trade, of travel, and its a huge impact on emerging infectious disease or disease emergence. And the quote here says that while microbial risks have been globalized, along with commerce, the corresponding health and protective measures for the most part have not. And those of us who are working in the front lines, I am sure, really know this firsthand. So in terms of the history of pandemics, I like this graphic. Na-update po ito. So una ko pong ginamit tong graphic na to sometime in April, I think. And since that time, lumalaki po ng lumalaki itong circle ng COVID. So what's really striking as we look at this graphic and compare the impact of the COVID pandemic in terms of death toll as compared to every other great pandemic in history, the only pandemic in modern history that is comparable, and of course it's much greater, is the HIV/AIDS epidemic. But already, COVID has exceeded swine flu, SARS, Ebola, MERS, and we are still growing. So if you look at the epidemic curve globally, we are still on the upswing. And again, we don't know where this will end, but of course, we have to take steps to be able to curb transmission. So we were not prepared. This is, of course, frustrates me, but it also does not surprise me. When I worked with the leprosy task force, I was able to see, albeit peripherally, how the data management system works at the where the local health system or the devolved health system integrates with the national healthcare system. And we have so many information systems. Merong leprosy ILIS for leprosy. There's the ITIS for TB, FHSIS, the schistosoma information systems. Ang dami-daming hiwa-hiwalay na information systems. And of course, this makes a big difference because the speed at which we report and validate and collect data is definitely affected because of the fact that this is all fragmented. And again, when we talk about data having to inform policy, it's so important to be able to have real-time data, which at the moment is really a challenge, as I understand. So these are the WHO criteria to lift restrictions. And maybe we can see now that our cases are rising again, that it's not just a matter of flattening the curve or controlling transmission, but that we have to be prepared to be dealing with this for the next months, possibly even years. So health system capacity to detect, test, isolate, and treat every case and trace every contact is much easier said than done. And these capacities and protocols and the staff, space, and systems are all things that should have been set in place beforehand. Unfortunately, they were not, and so we are in this difficult situation now. What I would like to see here as my personal role is to help educate, engage, and empower everyone through my school and through the training of the future physicians to be able to adjust to the new normal. So ito po yung mga waves. We of course have been talking a lot about the wave of COVID-19, and we're not even yet at the downswing. But there are other waves, not just second and third waves or surges of COVID, but the other corollary or collateral damage that occurs because of this pandemic. So there will be impact, resource restrictions on urgent non-COVID conditions. Yun pong mga may heart disease or diabetes who were not able to take their medicines or seek consult or do lab work. We talk about the post-ICU recovery of those who had COVID and not COVID also. There will be impact on interrupted care of chronic conditions. And last but definitely not the least is the wave of psychic trauma and mental illness that we have to anticipate so that we can also deal with it in the future. And this will be related to burnout, not only in the health professions, but in every other profession and every other industry, as well as the economic downturn that will definitely occur after this pandemic. So, Dr. Jillian talked from experience about the health system, and this is something that I try my best to teach our students, and I also try my best to advocate to our other faculty members, even those who are working as clinicians, because we have to prepare our future physicians and equip them with the necessary knowledge, skills, and attitudes. And the challenge in the education system is that um, because most of our faculty members are trained as clinicians, it is also difficult for them to understand, much less teach these concepts to our students. So the whole concept of the service delivery network and the continuum of care from disease prevention and promotion to curative care, which is where we have clinical care and where the clinicians and the hospitals have their role, and all the way to rehabilitation and palliative care. We have to be able to teach this to our students so that they will be able to find their place within the network and decide where they would like their role to be in the future. So I like to show this web, and I also second the motion that um, healthcare is an interprofessional thing. Healthcare delivery is definitely not only in the hands of the doctors, and we also have to talk about the links in the chain and understand our role as physicians. And for me to explain to my students their future role, together with the rest of the healthcare team, the nurses, the midwives, whether you practice in the front lines at the grassroots or you practice in the hospital or you do something else non-clinical like research or global health, there will always be teams and collaborations, and this is something that we need to be deliberate and purposeful in the way that we teach them. So universal health coverage. Just before the COVID pandemic struck, we were talking about the UHC law and what they would refer to as our UHC experiment. And maybe people are asking, what does UHC have to do with COVID, and what does UHC have to do with, yes, sorry.
Excuse me, sorry to interrupt, Maya, Doc
Mhm.
Maya. Kaya lang we're having problem with the screen. Hindi na po project, so sayang naman yung slides. Do you think
Oh,
you
I
can
see.
share again, or can you email it to the CHD
Mm.
or PM sa
Thank
CHD
you.
Messenger? Sayang naman. Okay,
Yeah, I
sorry to
understand.
interrupt.
Wait, let me think. Probably mali lang yung sa pag-share ko. Let me try again. But thank you for letting me know.
Sorry. Okay.
Lock the screen
So,
first. Let me try this again. Share screen.
so very interesting kasi yung iyong
Full
mga
screen na
social
lang siguro
science.
ako.
If not, baka pwedeng i-email mo, o padala by messenger sa
Is it showing
CBHP,
po? Hindi pa
CHD
rin.
desk. Ay, hindi pa rin. Kata,
Hindi pa
nakikita
rin.
ba?
Ayan. May delay lang yata.
Kita na ba by Kata? Sorry about that, folks. Kasi minsan nagkakaganyan talaga dito sa StreamYard.
Is it
So,
showing? Hindi pa rin po.
is it showing now, Kata?
Yan, okay na po. Okay na
Okay
po.
na daw. Okay.
Yeah.
Thank you.
Thank you.
Thank you.
Thank you. Thank you po for giving me heads up. Yan ang mahirap talaga sa webinars. Walang verbal cues, walang visual cues, and thank you for letting me know. So, as I was saying, minsan kasi para akong sirang plaka, always talking about public health, always talking about universal health coverage and universal health care and primary health care among a sea of clinicians who lots of times don't really understand where I'm coming from. But again, as a silver lining, I think more people are now understanding how important it is really to talk about public health and population based health as a complement to individual patient care. So, ito po yung ating UHC experiment, as they like to call it. And just before the COVID pandemic struck, I was part of a study group involving the private sector. And we were talking about, I was advocating to make space in the narrative for the academe, being that it is the academe that produces the workforce to be able to staff all these different functions. So now that brings me to the role of the academe in the integrated pandemic response. And I am a believer in value-based leadership because when we understand what values we hold, that will also guide us in making decisions with regard to what to prioritize, where to move forward, who to involve, what stakeholders to consult, and so on and so forth. So we were talking last year about digital transformation, and that's actually another interest of mine, digital health. Although I'm not techie really, but I got introduced to digital health a little bit by accident because I was part of the leprosy task force, and we had a project that we rolled out. We were actually able to get the DOH to adopt nationwide. It's Learns, which is a teleconsultation system for leprosy. So before this, I used to think that digital health was something for the resource rich settings. But as I began to delve into the literature, I actually saw that mobile health in particular, or telehealth or telemedicine that is delivered via mobile phones, is actually something that has a big place in underserved areas and in resource poor settings, such as the Philippines, because in the RHUs, the midwives, almost everyone has a phone and they use SMS or text. And so, if we can just be able to harness that to be able to improve access, and our interest at the time was focused specifically on leprosy, but it was like a proxy for access for health in general. But anyway, digital transformation, as we were talking about all the different opportunities, we were not prepared for COVID to come and move us all online with very little preparation. So this is from the Fortune 500 CEO survey, and they talk about how industry, how travel, how the technological transformation has really been accelerated by COVID, and how we will probably not go back to what we were before, even after the pandemic has already been controlled. Hopefully, not so far in the future. But then what does that mean when we talk about the Philippine context and all the resource poor settings and the underserved areas that don't even have electricity, don't even have running water. And this photo that I'm showing you is a photo from the post Yolanda mission that I joined in. Ano bang taon yun? I don't even remember. But the Philippine context requires us to understand the fragmentation of the healthcare system, the dominance of the private sector, not only in healthcare, but also in healthcare education. And this is really why we need to involve the private sector in public health and expand the conversation to talk about public health not just as a function of government services, but as a population based service delivery network that must include the private sector. So the majority of expenditure being out of pocket. Of course, these all are all conditions that existed beforehand, but are now aggravating the gaps and inequities that pre-existed, but now are widening because of COVID. So now, what is the new normal? And when we talk about silver linings, what are the opportunities that might emerge in this crisis? So crisis is difficult, definitely. I think we all feel that. Patients, doctors, students, everyone feels, this difficulty in transitioning. But also there are opportunities in crisis to take a step back and look at our practice and see what it is that we can improve moving forward. So this is a light bulb moment for me when the education sector started talking about the Frank and Chen paper. So it's a pretty long paper, and if you haven't seen it yet, this is actually a validation of the efforts of the community medicine sector. And this is a way to be able to expand our advocacy and our reach into medical education in general, in mainstream. Okay, so two conditions exist. Two transformative conditions are actually existing in the present age. The transformation due to technology, which is transforming both pedagogy and educational structures, and in the healthcare delivery side, also healthcare delivery. But also amidst the fourth industrial revolution and all the scientific advances of this age, there is still a lot of disparity. There is still a lot of inequity. And so, for educational institutions like mine, we reaffirm our fundamental obligation to still direct our education, research, and service activities towards addressing the priority health needs of society, whether the educational institution is a private or a public institution. So, what is the relationship of education and the health sector? It's a very close relationship because, like I keep on saying, it is the education system, the academe, that produces the staffing or the manpower for the health system. And so there has to be a very, very close coordination. So we need to talk to provincial health offices. What is it that you need? We need to talk with the DOH. We need to talk with the non-government sector and find out what it is that the workforce needs so that the education system can also include that in our curriculum. So, what are the real world skills that you have? Knowledge is one, and knowledge is important, but skills, attitudes, and values and ethics, these are other aspects and outcomes that cannot necessarily be measured by testing. Uh, Even more importantly is what we call the hidden curricula. Because if we are traditional education, which I underwent, talks mainly about textbook knowledge, but when but how much is relegated to the hidden curricula? How much role modeling is required to be able to develop those ethics and attitudes and values? And what I'm trying to say is that we cannot just rely on the hidden curriculum, and we cannot just rely on role modeling, because role modeling can either be positive or it can also be negative. And so we need to be, again, systematic and purposeful in how we embed these concepts into our curriculum. So we of course have legal frameworks. The CHED, the PRC produces regulatory requirements, and also we have program outcomes for medicine in the Philippines. So again, this was a light bulb moment for me because clinical competence is just one of 10 outcomes that we need to produce or develop in our medical graduates. The others are not so easy to teach or to test. communication, leadership, teamwork, collaboration, um, system-based approach to healthcare, nationalism, internationalism, social accountability, and all of these outcomes need to be embedded in every subject. So when we started talking about outcome-based education, tinatanong kami, halimbawa physiology, paano ko ituturo yung nationalism sa physiology? Paano ko ituturo yung social accountability um, sa anatomy? And the answer to that is that there are models and frameworks to be able to teach this. And I think it's wonderful that it is now mandated that every school and every subject needs to talk about these outcomes. And for those of us working in community medicine and public health, it's not difficult to teach this because these are experienced in public health and community medicine. But these are a challenge for the teachers. And so the next step will actually be to create a module to capacitate clinicians and faculty in the practice and the teaching of these non-clinical and non-traditional outcomes. So again, this is universal. So the American College for Graduate Medical Education talks not only about patient care and knowledge, but also about systems-based practice, which is defined as an awareness of or responsiveness to the larger context and health system, and the ability to call on system resources to be able to provide optimal care. So this is the marriage or the intersection of clinical care with public health or population-based health. So the CanMeds is another framework that talks about the varied roles, which is also parallel to the five-star physician model of the DOH, where doctors are not just clinicians but also educators, researchers, managers, collaborators, and social mobilizers. And again, these are concepts that we need to integrate into the curriculum of our medical students. So here are some things that I would like to share that we have done in St. Luke's in the past few months. So this is a research that is still actually ongoing. Its final analysis, where we tried to do a mixed methods analysis to try to find out perceptions about social accountability and how to insert these concepts into the narrative of the school and more broadly into the narrative of the health professions in general. So another research that we did was to be able to use education technology to promote professionalism and social accountability in the medical curriculum in the different subjects. So again, this was a mixed methods design study. And the output of this was that we were able to do a structured needs analysis in 2009 of the different sectors in our school, students, faculty, and staff, as to their needs in regard to education technology use. And this was invaluable, particularly as we were forced to transition online during the COVID pandemic. So another output of this study was 10 e-learning modules that helped us that helped provide us with a ready and easily scalable resource for our students when particularly the clinical junior and senior interns or clerks and interns who were pulled out of their duties without being able to say goodbye. Just one day they were going on duty and the next day they were not. And of course, we had to ask ourselves, how do we teach them? And so for the first 1 to 2 weeks, while our faculty were still trying to transition their clinical teaching online, we gave them these modules: academic integrity, patient autonomy, ethics in publication, health program planning, patient-centered interview, suicide risk prevention, waste management. So these modules that were developed are easy. They run themselves. You just have to give them to the students, and they can undertake these modules on their own time at their own pace. So basically, what we were talking about in education was our recovery plan or our service continuity plan, which is also something that, of course, needs to be applied to any setting, whether it is healthcare delivery or transport or banking or whatnot. So opportunities in crisis appeared for those who are creative, and I really like this how the fashion industry was able to support the frontliners in terms of providing PPE, and I think this was a wonderful way to be able to pivot an industry into becoming essential during the COVID pandemic. So change management is something that we are undergoing even before, during, and after COVID. And I'm running out of time, I think. So, of course, the digital divide is definitely something that we need to talk about as we endeavor to not leave anyone behind, whether students or patients. And I really don't have all the answers to this, and we are a small school, so we were I'd like to think that we were able to adequately support our students who had difficulty with connectivity and gadgets, but this is a much more difficult issue to be able to address when we talk about bigger universities with a larger scale than our small school. But I also wanted to share our initiatives after COVID. So credit to Dr. Athena De Paduatan, our alumna who's also an alumna of the Doctors to the Barrios program, because she is now heading Lingkod Lucan, an out-of-the-box and authentic learning experience for service learning. So we were intending this to be sort of like a classroom in the field, because we were talking about this pre-COVID. But now that we cannot teach our students in person, it has become an e-service learning activity. And we're really excited to be able to pilot this for our first cohort of students starting July 16. So I'd also like to share student reflections on the role of a medical student. So these are actual reflection papers written by our students, because as a means also of helping them to cope, we asked them to write reflection papers to help them process. And the chair of our ethics department was the one who read them, and these are some of the insights that he shared. So realizations about the social order, power asymmetry, conflicts between the economy and public health. Um, we had students who lost family members, and basically that service can come in many forms and can take many platforms, and that this pandemic for many of them ignited their passion to serve. So this is also another. We collected so much data again in our efforts to be data to be data informed in the way that we do our policy, and these are some of the perceptions of the faculty as to what instructional methods are effective versus ineffective. So as I get come to a close, so communication I think is such an important thing, whether you're talking about education or healthcare. And again, the academe plays a very important role in communication. So here's an example of confusing communication, and this is quite old, actually. I think about a month old. But the bottom line is that the public gets confused when there are conflicting messages, and so we have to be able to do our part in uh, in framing the narrative and trying to share evidence-based information to the public, and and to be able to combat the quote unquote infodemic that exists during the COVID pandemic. So here are infographics. A lot of the projects that were done towards the last semester, our assessments were shifted to project based assessments. And many of the faculty and departments asked our students to make infographics. So, ang dami-dami po namin nagawang mga infographics. We have infographics in obstetrics, surgery, medicine, in different languages. May nakita pa po akong Kapampangan, and these are part of what we would like to contribute, again, to improve health literacy, to improve awareness about COVID and how to keep ourselves safe during this COVID pandemic. So coping strategies during the quarantine, again, very important self-care for everyone, students, for faculty, for ourselves, because everyone is finding it really difficult and feeling so many kinds of griefs during this difficult transition. So I think ultimately we need to find kindness, and this is a message that we have been sharing repeatedly in our different assemblies, that we have to be kind to everyone. Faculty need to be kind to students. Students need to be kind to faculty, because everyone's adjusting. Faculty and students need to be kind to patients. And finally, we also need to be kind to ourselves. And this is an initiative where we asked for messages for frontliners and for patients, and which we sent to the different hospitals. So moving forward, what do we need to be able to do, and what is our role in the academe? We need to teach rapid evidence review and appraisal. We need to craft and recalibrate education and practice guidelines. We need to revisit ethical considerations that are changing during COVID. And finally, formulate a research agenda and conduct intensive health promotion and awareness building. So what I have learned working in the education mainstream, because when we talk about silos, there's the clinical silo, and then there's also the community medicine silo, and we need to be able to bridge these two to be able to really make an impact. So what I have learned trying to work in mainstream education is that I need to use a language that they can relate to. And professionalism is a concept that is very close to every clinician. So, but it's really not so much different from the principles of Alma Ata or community medicine, the primacy of patient welfare, altruism, respect for patient autonomy, and social justice. So these are the vision and mission of my school. And I would like to think that at this time, my own personal mission and my what I feel my role is in promoting and advocating for public health is in alignment with the mission and vision of my school. And so we would like to work to do whatever we can in our limited sphere of influence. So we all have different hats. So I am a dermatologist, I am an educator, I have worked in the government at the grassroots, I have worked in an NGO at the grassroots, and now I am doing what I can to be able to frame the curriculum to include the concepts of public health and community medicine. And again, we do what we can. We try to celebrate our little milestones, our little successes, as if they were milestones. And really, there has to be a bridging of medicine and public health. Only this way can we be able to protect ourselves from this pandemic and the future pandemics that will occur. And so this is a quote from the esteemed Dr. Nelson Mandela, who has a lot of quotes about education. And this particular one says that the power of education extends beyond the development of skills that we need for economic success. It can also contribute to nation building and reconciliation. What a lot of people may not know is that Dr. Nelson Mandela was actually educated through a distance education institution that allowed him to be able to access education during the difficult political climate of apartheid. And so now that we are forced to teach students under a distance education mode because we cannot teach our students in the classroom, I hope to be able to again harness the ability of distance education to serve as a platform for inclusivity and inclusion in education, and always teaching the importance of the social determinants of health. So I believe in my heart that service is something that is inherent to the practice of medicine. And this has been true before COVID, and it is true all the more now. And students come into the school, the medical schools, with a very idealistic ideation to be able to serve. And as educators, I think that it is part of our job, our duty, to be able to nurture that idealism so that even when they graduate, they will still have that dedication to service of humanity. So with that, I thank you again for this opportunity and maraming salamat.
So thank you very much, Dr. Maya. Can you hear me? Yes, so thank you for clarifying the relationship between our healthcare system and education, especially the education of our future frontliners and future physicians. Marami tayong natutunan kay Doc Maya. Maraming bagong concepts or concepts of innovative concepts in health sciences education, especially in medical education. So I'm particularly impressed with how you are embedding the values and concepts of ethics and social accountability into the curriculum and the science courses, no? Tapos yun ding pag-bridge ng clinical care and public health. Ganun din, napakagandang pag-discuss mo noong paano yung adaptation na ginawa ng ating medical education, yung pag-mix ng mga methods or something like blended learning, no? Yung pag-evolve ng service learning into e-service learning at yung pag-inculcate din sa ating mga students at pag-nurture ng kanilang passion to serve, no? So, napakaganda rin yung shinare ninyo na Human Kindness Initiative, no? So, mayroon ka pa bang ano yung pwede bang malaman kung ano yung sa tingin mo method na mas talagang naging sa karanasan ninyo was able to prepare the students and into the future doctors dun sa kanilang role, especially at the time of pandemic? Or you can answer that later.
I think po
Pwede.
it's so important to be able to have a participatory approach because really the largest part of the education is from the clinicians. And so we really have to bring the clinical faculty on board. And we have found a lot of, tawag namin dun found pilots. So for example, ENT actually had a module on health program planning for ENT. So medyo, I understand na nahirapan po yung mga faculty members kasi hindi naman po sila public health in their background. Kasi they're clinicians, but all the same, they were willing to learn, they were willing to teach what resources are available in the DOH, in the NGOs for students. And I think that was a wonderful initiative of theirs. Another one was the social pediatrics module for our second year students. So again, mga clinicians po ito, but they were the ones who designed the module and they talked about community pediatrics, they talked about the social determinants of health. And I think it's such a validation of the fact that what we have been doing in the community medicine sector is now coming mainstream. And now we can really make a bigger impact by sharing our stories.
Thank you. So with that, pwede ka pa ba later for questions, Takmaya?
Yes
Sige.
po.
So thank you again. So we can proceed to the next speaker for this afternoon. We have Dr. Reginald Pamugas, who is a trained psychiatrist, and actually he's more of an advocate. He's an officer of the Community Medicine Practitioners and Advocates Association for the NCR region. And he is also very active in health and human rights. He's an officer of also of the Health Action for Human Rights. And he is also awardee of the UARMMC alumnus special award for community service during their 50 years of existence. So can we hear now for to speak on the legislative advocacy efforts for the welfare and protection of physicians, as well as the other efforts that are being done for the healthcare system. I think this is a good opportunity for us to make other people see that those of us in development work, in social development work, working in the grassroots and social activists are not only good at criticizing, but also at what to do in terms of improving or contributing constructively for the changes that we want in our healthcare system and our society in general. So let's welcome Dr. Reggie Pamugas.
Okay. Magandang hapon po sa ating lahat. Narinig niyo ako? Sige po. So, maraming salamat sa pag-imbita sa akin dito sa CPRH sa magandang topic. So, yung opportunity din na makapagbahagi din dito sa webinar na to. Okay. So, salamat din doon sa mga naunang speakers si Dr. Lee at si Dr. Santos. Maganda yung mga na-share nila, clear at saka informative regarding yon sa mga information binahagi nila. Okay. So, allow me to share also my screen. Wait lang. Share screen. Wait lang. Saan ko ba hanapin yung screen ko? Oh, shit. Wait lang, Okay. Teka lang. Pwede pa magtanong kay Kata kung paano share yung screen.
Sa baba, merong share screen after nung stop
Okay,
mute.
na-click ko na, pero hindi ko makita yung PowerPoint ko.
Sa applications window po, Doc.
Sa application. Alright, thank you.
Okay, Doc.
Ayun pala. Ayan. Okay. Wait lang. Nakita niyo na? Parang itim. Okay, wait lang. Hindi ko sure kung bakit itim yung screen. Stop sharing ulit. Wait lang Sorry for technical difficulties. Okay, application window. Okay. Parang walang lumalabas na Walang lumalabas na PowerPoint ko sa...
Naka-open na po yung PowerPoint niya, Doc.
Yes, naka-open na siya.
Opo. And then, na-click nyo na po yung share screen sa baba.
Yes.
And then, i-choose nyo po yung tab na application window.
Application window. Wala siya doon sa Wala siya doon sa site or sa screen. Ulitin ko, wait lang.
Sige, Doc.
Sige. Share screen. Application window. Wala siya doon sa site. Hindi ko sure. Nakalagay lang doon yung StreamYard Google. Yun lang. Iba. Ito yung nangyari kanina. Hindi ito. Sorry, wait lang
Bali, hindi po yung entire screen yung isi-share, application window po.
Share screen. Application window. Okay. Sige. Pero wala yung ko. Wala yung PowerPoint ko sa application window.
In-scroll nyo po hanggang baba. Baka
Yes.
po nasa bandang baba.
Wala siyang scroll
Ay, sige po. Ganito na lang po, Doc. I-PM nyo na lang po sa akin yung presentation. I-drop nyo na lang po doon. And then, pwede pong ako yung mag-share screen.
Alright. Sige. Wait lang Bakit ganun? Sandali lang. Okay. Paano ko i-drop pala? Sorry.
Yung file po, i-drop nyo lang po doon sa chat box po ng private message natin.
Sige, wait lang. Private. Parang ayaw. Anyway. Iba. Anyway, sige, ano ko na lang. Hirap eh. Ayaw siya madrag. Okay, sorry. Sige, anuhin ko na lang. Sige, so sorry sa technical difficulties, medyo mahirap eh. So, magandang hapon sa lahat, ano. So, yung topic ko is more on yung sa advocacy ng mga doctors regarding doon sa struggle, no? O yung kung ano nang nangyari ngayon sa mga doctors sa ating current healthcare system, no? So, yung madalas yung experience diyan pag tawag nito pag nasa mga communities kami, no, doing medical missions or projects sa mga communities, palagi yan na itatanong palagi ko natatanong sa mga bata pag may nami-meet doon na kumusta ikaw, anong gusto mo paglaki mo. So kadalasan diyan sabi nila maging teacher or engineer, abogado, pero ang hindi madalas mawawala is yung maging doktor, no? So yun yung isa sa mga parang maganda pakinggan kahit bata pa sila, nakikita na nila yung kung bakit na tawag nito, gusto lang maging doktor, no? Pero ang sa loob-loob ko parang hindi ganoon kadali, no? So pag titingnan natin ang haba ng panahon, almost 10 years, no, na bago ka maging doktor, no? So nandiyan yung mga pre-med courses hanggang med proper, nandiyan pa yung internship, no? So parang hindi siya ganoon kadali. Tapos para maging isang doktor naman, maliban kung halimbawa kung matalino ka, meron pa yung mga financial constraint, no? So magkano ba ngayon yung mga tuition fee ng mga medical schools? Laki na, no? So siguro nasa 160 or 180,000 per semester 'yon, no? So 4 na taon 'yon, no? So hindi siya ganoon kadali. Although meron ng mga scholarship yung mga medical schools, lalo na yung mga public schools, hindi pa rin siya assurance na pwede maging doktor kasi nga, 'di ba, yung isa pa rin yung dedication, no? Kasi 'di ba pag nagpupuyat sa pag-aaral, nahihirapan sa mga lesson, parang yung sinasabi natin yung isa sa magtutulak sa iyo para magtuloy-tuloy ka maging doktor is yung dedication talaga kung bakit mo maging doktor, no? So bago pa naman dumating yung COVID, nandiyan na yung mga doktor, no, na nangangalaga sa atin. Tapos ito ngayon, unexpected, lahat nagugulat sa crisis na to, yung COVID-19 crisis, nandiyan pa rin yung mga doktor, no? So nakikita nga natin na tinatawag na natin sila na parang frontline, for actually naman sila, dapat nasa isa sa mga last line of defense sila, no? So dapat ang nangunguna diyan sarili natin, pamilya or komunidad, no? Sila sana yung nangunguna pag yung first line ng mga defense or handling doon sa COVID-19, no? Kasi pag mawala na yung mga doktor, lalo na yung yung latest na na dami na naapektuhan ng mga healthcare workers, no? Sa latest na data noong July 5, no, sinasabing almost 3,513 na mga health workers ang naapektuhan, no? So marami na ring doctors ang namamatay, no? Nasa 34 na ang pinaka-latest noon a few weeks ago ata yung isang anesthesiologist from isang sa Cavite Hospital, no? So nandun yung danger, no, na pwedeng sa buhay ng doktor, no, na delikado, no. Pero kahit pa man, no, dahil yung sinumpaan nga ng mga doktor, no, na Hippocratic Oath, no, so tuloy-tuloy pa rin silang nagsiservisyo. Okay? So kung nababasa nyo rin sa mga balita ngayon, marami na rin mga hospitals, no, yung public man, PGH, Makati Med, St. Luke's or Medical City, nagsasabi na napupuno na sila, no? Nasa sinasabi nilang danger zone na, no? Yung ano na overwhelm na yung mga hospitals natin, no? So pag titingnan natin, habang dumadami yung pasyente, dumadami din yung kailangan alagaan ng mga doktor, no? Ng mga pasyente, no? Kasi hindi yan pwedeng iwanan, no? So, ang ano naman, ang doktor naman is hindi naman din siya hindi naman siya hiwalay doon sa ating healthcare system, no? So, part din siya doon, no? So, palaging sinasabi ito, no? Although binanggit to sa mga nauna ng speaker, no? Yung Magna Carta of Public Health Workers. So, nakikita natin na based doon sa latest na data ng PRC, no? Yung Professional Regulation Commission, ay mayroon ng 149,000 plus na mga doctors. Pero yung actively na nagpa-practice siguro or nagre-renew ng kanilang mga license is nasa 81,000 lang, no? So pag titingnan mo yung ratio ng doctor to population, sobrang layo, no? Nung 2017 nga, in-estimate niya ni Secretary Obial noon, isang doctor to 33,000 na population. Masyado siyang malawak doon sa recommendation ng World Health Organization na 1:10,000. So, yung mga binanggit kanina din sa mga naunang speaker, diba, si Dr. Lee, yung sa kanyang lugar niya, so kulang talaga, no, yung mga doktor, no, kaunti lang yung mga doktor. So, alam mo yung mahirap yung services, no, yung access doon sa services, kawawa yung mga naging pasyente, no. So, dahil sobrang kulang yung halimbawa yung mga doktor, tapos mal-distributed pa. Sabihin nun karamihan is nasa city-based, no? Halimbawa dito sa NCR, mas marami ito compared doon sa mga provinces, no? Sa Mindanao or sa mga GIDA area, no? Yung geographically isolated and disadvantaged areas, lalo pang walang doktor. So, marami din sa mga doctors ng overwork, underpaid, public, lalo na yung sa private, no? Kaunti lang yung nila, yung mga nakukuha nila ng mga sweldo, no? So, ang doktor naman, although part siya ng healthcare system, hindi naman datin din hinihiwalay siya sa iba pang mga yung multidisciplinary na mga ibang team, no? So, halimbawa sa mga nurses, ang maganda ngayon dahil merong comprehensive bill, nursing bill na sinusulong ngayon sa Congress, no? Yung House Bill 3477 na so hopefully pag naipasa ay maganda siyang maidulot na polisiya doon sa ating mga kasamaan na healthcare workers, sa mga nurses. Tapos yung Magna Carta naman, no, since 1992 pa yung Magna Carta of Public Health Workers, no, Republic Act 7305. So matagal na siya kaya lang yun ngayon ang gusto nga natin holistic yung pag-address sa healthcare system natin na hindi lang public health din, pati dapat yung mga doctors na nasa private hospitals o private clinics, no. So importante na tawag dito, sila din ay mabigyan din ng welfare or protection, no. So hindi natin hinihiwalay yung doktor sa iba pang laban or sa ating kabuuang healthcare system. So ngayon sa Congress kasi ngayon merong sinusulong na isang bill, no, yung parang maging batas amending yung Medical Act of 1959, no, yung Physicians Bill ngayon, no. So siya, maraming section doon. So isa dito is yung regarding regarding doon sa Universal Healthcare Act, no, yung Public Act 1122-3, no, na sinasabi doon sa section 23 yung National Health Human Resource Master Plan, no. So bago pa lang batas to, mukhang naabutan ng COVID, hindi na-implement ng maayos, no, or hindi pa talaga na-implement kasi nga understudy pa or paano pa nila i-implement, tapos ngayon naabutan ng COVID. So, patsi-patsi, no? So parang hindi siya talagang sagot doon sa problema, doon sa sa healthcare system natin. Maganda pakinggan actually, maganda 'yun Universal Healthcare Act. Kaya lang pag hinihimay mo or titingnan mo siya, hindi rin na-address basically yung iba pang concern ng mga doctors or iba pang health workers, no, or yung sinasabi nating DTTB. So, lately nga, 'di ba, nag-order yung DOH ng deployment dahil doon sa augmentation sa mga doctors sa Cebu, no? So, ayaw naman natin na pabayaan ang Cebu, no? Pero kaya lang, pag inalis mo yung mga DTTB doctors doon sa kanilang mga GIDA areas, paano na yung mga tao doon? Paano na yung access din ng mga tao? Kaya nga binigyan ng DTTB doctors kasi nga hirap sa access, no? So lalo silang kawawa din, no? So pag nakita natin, although nandiyan yung DOH, no? So tingin ko naman ginagawa yung lahat naman ng makakaya, pero tingin natin kulang pa, no? Ang nakakatakot lang pag na-politicize yung function ng DOH, no? So yan yung naging problema, no? Na hindi ma-address talaga yung health human resources or yung sinasabi nating master plan. So isa pa doon sa provision ng Physicians Bill na isa din na tinututulan namin, no? Yung sinasabi ng integration ng mga doktor, no? Although lahat ng mga doctors may karapatan doon sa association, pero itong bill na to na pinasok dito sa Physicians Bill, yung amending the Medical Act of 1959 is para siyang i-co-op yung buong yung pagpa-practice mo as doctor. So nakikita namin na pwedeng hiwalay, no? Isang bill for yung mga para ayusin yung mga doctors, yung organization. Pero yung recommendation namin or proposal namin dito sa bill nito, dapat council siya, no? So parang hindi isang organisasyon ng mga doktor, kung hindi, dahil may karapatan ka to free association, no? So member ka ng Compass, member ka ng iba-ibang organization ng mga doctors, so may karapatan ka doon. Pero itong council is under DOH, no? So kasi nga nakikita natin na yung state responsibility sa ating public health at saka healthcare system is dapat responsibilidad ng government na dapat hindi niya ipapasa sa isa lang na private institution or private doctors organization, no? So parang malaki naman yung role diyan doon sa sa DOH, no? Yung sa Health Human Resources Development Bureau na pwede nilang ayusin 'yon, no? So part doon sa proposal namin, no? Kasi nakikita namin na importante yung state role regarding doon sa healthcare system natin, na sana makapaggawa yung yung state, yung government natin ng National Medical Workforce Master Plan. Kung hindi yan, yun yung inaayos namin na proposal, no, para ma-coordinate with various stakeholders regarding doon sa mula sa production or mula sa enrollment ng mga doctors, mula sa distribution kung saan siya pwedeng i-deploy, at saka paano ma-maintain yung healthy number of doctors, no? Kasi pag na-compare natin yung Pilipinas sa iba pang bansa, parang medyo malayo talaga, no? So halimbawa doon sa Germany, halimbawa sila may limit yung numbers na pwede maging doktor, no? So kung halimbawa kung 500 lang this year, 500 lang. Kung hindi ka na makapasok, kuha ka muna ng ibang mga courses, kuha ka muna ng ibang mga education na tawag dito, makatulong sa iyo, no? Or makatulong sa government kasi nga puno na. Sa Pilipinas, 'di ba, kung sino lang yung may pera or gusto maisip na magdoktor, papasok kasi ang daming medical schools, siguro mga 50 plus na yung medical schools. Tapos masobra na. Tapos hindi kontrolado in terms of yung paano ma-deploy, kasi nga kung lahat magde-decide sa city, kawawa yung nasa provinces, kawawa yung nasa mga GIDA area, no? So parang maganda yan, ma-maintain yan yung ng government, no? Yung medical workforce. Tapos yung maayos din yung in terms of yung medical education. Kanina binanggit niya ni Dr. Santos regarding yung importance ng medical education, no? Paano maging nationalistic, paano mag-address doon sa public health, kasi karamihan ng mga teachers ng medical schools is clinicians, no? So napapansin ko nga yan simula pa lang, first year pa lang, sino nagtuturo ng mga biochem, anatomy, physio, mga specialty, halimbawa sa anatomy, surgeon, parang gano'n. So nakikita talaga nila yung importance ng specialty, kaya doon sila druin. Kaya naisip ko nga kung general practitioner o yung doctor na marunong naman, no, public health na doctor na marunong naman magturo biochem, physio or anatomy, parang gano'n. So may isang ganong option din siguro, no? So part doon yung medical education na makakatulong in terms of how do you mold yung mga incoming doctors or future doctors na eventually maging maging nationalistic or patriotic doon sa bansa in terms of addressing the public health care. or yung kabuuan na healthcare system natin. So, part dito doon sa proposal nga doon sa Physicians Bill nga in terms of yung mag-create ng National Medical Workforce Master Plan for that, no? Tapos, to address regarding yung economic welfare, no? Kasi binanggit din kanina sa previous na mga nauna nating speakers na marami din yung doctors na kulang yung mga sweldo, kulang yung natatanggap na mga allowances. Although merong Magna Carta on public health workers, pero minsan hindi talaga siya nabibigay, no? Kasi di ba subject to funds, ability of funds sa mga hospitals, parang ganon. So, hirap din, no? So, importante. Kaya nga, minsan, pag yung DTTB, nung nagsimula nung time ko, mababa lang siya. Nasa 20, 30s. Ngayon, almost 60 to 70,000 na per month. No? Ang laki na para lang ma-entice yung mga doctors, no? So, kaya lang, syempre, isang, parang nakikita natin na parang lang siya, band-aid solution sa isang sitwasyon kasi 2 years ka or 3 years lang. After nun, alis ka na. Kung walang susunod sa'yo, sayang din yung pinaghirapan ng mga naunang DTTB doctors, ano? So, yung ganong plan nga, no? So, importante siya na mapag-aralan ng ating DOH, no, for that. So, yung pangalawang proposal namin, part doon sa pag-provide ng mga dialogues, venue solutions doon sa medical practitioners, yung continuing development ng service-oriented, no? So, kung bakit ka nagdodoktor, kasi alam mo yung purpose mo regarding doon sa service na ibibigay mo back to the community, no? So, hindi yung nagdodoktor ka kasi alam mo pagkatapos mo mag-abroad ka na agad, parang ganon, or babawiin mo yung nagastos na magulang sa'yo. Parang, although hindi naman natin sinasabing masama talaga kasi kung yun naman ang purpose mo, pero ang gusto natin is mamomold yung mga future doctors na maging compassionate, empathic regarding with our fellow Filipinos, no? Maging mabait sa ating mga pasyente na mga kapwa Pilipinos. Okay, so yun din. Yung isa naman din doon sa continuing development, yung halimbawa yung sa CPD, kasi marami din mga public doctors na nahihirapan silang gumagastos din, no? So, importante kung merong mga ganong continuing medical education, sasagutin niya ng mga government hospitals, government clinics, kung saan sila yung mag-aayos doon sa registration gastusin para magtuloy-tuloy yung mga medical education or information na mga nagbibigay ng services, no, public health services naman. Yung sa huli, in terms of yung proposal namin doon sa pag-amend ng Medical Act of 1959 is yung protection ng mga doctors, no? So, importante ito. Nakikita na natin to, experience, no? Halimbawa, kung babanggitin ko lang, okay lang, yung, halimbawa, yung si Dr. Jean, no? Yung isang professor sa UPPGH, no? Nung join siya ng rally regarding increase ng public health budget, no? Doon sa mga public hospitals, tinetreat siya, no? Regarding dun sa buhay niya or sa buhay ng family niya. So, ganong protection ang gusto nating makita din or magawa ng paraan ng government. Or, halimbawa, yung doctor shaming, no? Yung nag-react lang yung isang doctor regarding doon sa methods or yung mga ways how to address yung COVID-19 na nakita ng doktor na parang hindi naman talaga siya pinaka-primary, pero nagre-react yung governor, no? So, parang kawawa din yung doktor, no? Na kinukumpara siya sa isang big time na or matagal na practice na doktor, no? So, parang ganon. So, tingin ko hindi siya nakakatulong din for that, yung papahiyain mo yung doktor. Parang nagdoktor naman siya para tumulong, hindi naman kailangan siya pahiyain, no? Sa publiko. At saka sa huli, protection sa mga doctors in terms of yung harassment, intimidation, coercion, and especially yung deaths, no, yung mga AJKs. Kung naalala natin noong 2017 si Dr. Perlas, no, yung binaril doon sa Mindanao. So parang ayaw natin maulit yun, no? Ayaw natin mangyari yun sa mga kapwa doctors natin. So importante din siyang mapoprotektahan yung mga kasamaan natin doctors, lalo na yung mga nagpa-practice sa far-flung areas or yung mga nagsasacrifice ng kanilang services, no? So, away from their family, away from yung comfort nila sa city para magbigay ng access ng healthcare doon sa mga GIDA areas, no? Tapos ganyan ang mangyari sa kanila. So hopefully itong proposal namin in terms of yung pag-amend ng Medical Act of 1959 ay makatulong in terms of sa mga kapwa doctors at saka eventually ma-address yung healthcare system natin, no? Kasi hindi naman natin hinihiwalay yung doktor sa healthcare system at saka hindi natin hinihiwalay din yung health sa buong karapatan din ng mamamayan, no? So yung right of health kasama siya doon sa right of politics, right ng cultural, right of civil and social and everything, no? So hopefully eventually maintindihan din, no, sa ating mga kasamang doktor regarding dito sa paano natin ginagawa ng paraan yung pag-address ng healthcare system natin, lalo na sa panahon ngayon ng COVID-19, kasi nakikita natin talaga na parang parang kulang yung response ng ating government, yung DOH, in terms of addressing the public health crisis. So yun lang po, maraming salamat po.
Mga iba't ibang efforts na ginagawa rin in terms of legislative advocacy at policy advocacy sa ating hanay sa health sector. So maraming salamat sa ating mga speakers ngayon. Pwede na tayong magsimula ng ating question and answer section or portion ngayon. So, meron na ba? Ata. Pasensya na po. We apologize for the glitches dun sa technical aspects nitong ating webinar. Pare-pareho tayong nag-a-adjust. Lalo na kaming mga seniors. Medyo tech challenge. Okay. So, nandito ang unang question natin. Naku. Kung sino ang makakasagot, no? Saan na po tayo sa usaping validity of the data that the Department of Health released? How can we really truly tell if the actions of government and private organizations to reduce risks of further COVID infection has an effect? If data is true, indeed the numbers are rising, but people deserve to be properly informed. There is not enough support. Pati ba naman information is still a problem. So can any of our speakers respond to that? Or Doc Jillian or Doc Maya, both in tropical medicine and in the front lines?
Okay, sorry. Hi.
I can't speak for the DOH. I can only speak from an academic perspective. And siguro
Okay.
that knowing what we know about the health system capacity pre-COVID, I'm really not surprised that there are delays in reporting, delays in validation. But what I think might be a possible way to move forward is to use technology. Hindi naman ako, hindi ako techie talaga, but I've really seen how technology can accelerate data validation, and hopefully there can be a way to really integrate all the different sources of the data through a single integrated database. And I think if there are funds, then and that can be prioritized, this will really contribute a lot to speeding up data reporting and validation. That's my thought from the academe.
Okay, thank you, Dr. Jillian.
Okay.
Dr. Lee,
Nakalimutan ko na kailangan ko siyang... Alright. So, yung problem din kasi, expand ko lang ang sinabi ni Dr. Santos about yung madaming sources ng data. Kasi right now, wala namang unified data collection system ang DOH with regards to yung mga case investigation forms or CIFs ng ating mga COVID-19 patients and suspects. So, para lang may idea tayong lahat, ang nangyayari kasi dyan ay ang CIF mismo, 110 pa rin siya. In this day and age, kailangan mo siyang isulat sa isang papel at ang papel na yon ay dito sa setting namin. I don't know how everyone else does it, pero kahit sa Manila, sinusulat nila to sa papel and pinapadala sa provincial na DOH office. They send the report to the regional DOH office, tsaka palang either na-encode siya sa level ng region or na-encode siya sa level ng province. And yung testing pa, ginagawa pa yun sa hiwalay na testing facility and then they send the results. So, iba yung process ng pag-report ng suspect cases, iba pa yung process nila ng pag-report ng results ng yung results ng testing. And once nilabas nila yung results ng testing, iba pang process ang pag-validate ng DOH ng data because they get the data from the rural health units, from the district hospitals, and from the testing facilities para ma-sure sila na walang nagduduplicate. And hindi din enough, based sa naririnig ko sa Department of Health, hindi din enough yung personnel na meron sila right now to handle this kind of information. Ang isa pa din, kahit na maganda ang kanilang data reporting and ang kanilang data validation process, hindi pa rin maganda ang, yung data na nakukuha pa rin natin ay hindi pa rin nagre-reflect sa actual na situation. Kasi kulang na kulang pa rin ang ating testing capacity. Sa Caraga region, kung nasan kami, sa Dinagat, Surigao del Norte, Surigao del Sur, Agusan del Norte, Agusan del Sur, our nearest testing facility is sa Davao pa. So that's still 12 hours away. Konti lang sa mga cases namin ang natetest. Parang chine-check pa yun ng DOH, talagang nagka-qualify ba siya? Kung exposure history lang sa confirmed case, hindi nila tinatanggap kahit na in theory, kung maganda, part ng contact tracing process mo ang pag-test kahit na asymptomatic close contact. So, hindi pa rin maganda ang ating picture sa spread ng COVID-19, especially sa mga provinces na limited ang resources and limited ang testing capabilities. So, yung pag-scale up nito, hindi lang, sa reporting, yes, sa technology na kailangan gamitin to streamline your data collection process and your data reporting process, oo, pero kailangan din i-scale up ang testing pa rin. Yun lang.
Okay, thank you sa mga sagot. Merong idadagdag si Reg?
Dadagdagan ko lang, no? So,
Pamugas.
Okay.
Okay.
So, itong pagdating ng COVID, dahil unexpected to lahat, pero nakikita natin yung results ng COVID-19 sa healthcare system natin, no? So, doon sa nangyari, yung na low-tech, no? Yung low technology, yung sinabi nga ni Dr. Lee, di ba? Sinusulat pa nga sa papel, di ba? So, yung cheats nga, yan, lumang-luma, no? Na i-input doon sa computer. So, low-tech na siya, kulang pa sa mga human resources, no? Kulang sa mga staff na pwede mag-contact tracing, ganyan-ganyan. At the same time, ang problema pag na-politicize yung data, no? So, instead of transparency, na ito yung data natin, bibigyan mo ng ibang layer ng fresh cases o iba-ibang term na napapalito sa mga tao, no? So, yung term na parang dapat ilabas na lahat ng information or ito yung information natin, kung ida-downplay nila na wag ganyan kadami kasi baka matakot yung mga tao or ma-politicize nga in terms of yung acceptance ng DOH na wala kaming kakayahan. Tingin ko mas better yun no? Naaminin naman ng DOH na ito yung laki ng information, ito yung laki ng mga cases na hindi kaya na dapat magtulungan. Instead of ganun, mas madali yun kaysa bago-baguhin yung information, no? Or babaguhin yung mga terms na nakakalito lang instead of sabihin na may pagkukulang talaga ang government or DOH para ma-address itong COVID-19 na data. Yun lang po. Salamat. Naka-mute po kayo, ma'am.
Okay, salamat. So, natukoy lang ng ating mga resource persons yung mga gaps pa sa ating healthcare system sa information technology at saka sa health information system. So, any other questions? Okay, from the Health Alliance for Democracy, batay sa inyong karanasan, ano po sa tingin niyo sa kalagayan ng public healthcare system sa Pilipinas sa ngayon? Nakakatugon pa ba sa lumalaking needs ng mamamayan? May obserbasyon na lumalaki ang papel ng private sa healthcare na nakita sa COVID-19 response at parang nahuhuli ang government o public healthcare. So, sino sa ating mga resource persons ang pwedeng sumagot nito? Yes,
Iniisip ko pa
Okay.
po kung ano kasi syempre I work in private education but I'm not a private provider. So dun po sa mga naging pag-aaral sa universal healthcare, yung ating UHC law experiment kasi it never really got off the ground yet. May iba't ibang roles po kasi yung government. Government can be a provider the way that it does through the DOH hospitals and through the local the RHUs and the provincial health offices, where their direct services are provided by the government. But also the government can be a payer via PhilHealth. And again, I know there are a lot of complicated matters, but the fact is that if you look at the healthcare complement, the majority is really in the private health, in the private sector. So the question is, how do you harness that and to be able to provide care where it is needed most? And I think that's where the challenge will really lie. Because if we rely solely on those who are employed by the government, there's not enough people, right? So maybe the funds can be spread out, but then of course you would have to lower the cost kasi hindi naman pwede magbabayad yung government ng private healthcare rates. You have to be able to distribute the resources. So I know it's very complicated, but I think we need to look at all the different possible permutations to be able to deliver healthcare.
Okay, thank you. Si Dr. Lee has something to say.
Okay. I-add ko lang din sana kasi tama yung bulk nga talaga ng ating health professionals ay nagtatrabaho sa private sector. Pero if we're going to look at it din sa long term, parang yes, gusto natin na ma-harness yung resources ng private sector to work for the betterment ng karamihan ng tao sa Pilipinas, especially ngayon na nagmamadali tayo. Kasi pandemic nga siya. Ang gusto natin ay fast mobilization at hindi siya nagawa ng ating national government. May mga ibang local government units na nag-step up, nag-step in, Marikina, Pasig, Iloilo. Alam naman natin yung success stories nila, but unfortunately, karamihan ng local government units ay hindi kasing yaman ng Marikina at ng Pasig at ng Iloilo, and wala sila ng leadership, ng direction, ng good governance principles na magdidirect sa kanila na mag-step in sa level na nagagawa ng ating parang pinaka-naririnig na LGU success stories. So in the gaps na naiiwan ng national government and ng local government, nakikita din talaga natin na nagse-step in ang private sector. First kasi sila yung may madaming resources, may incentives din sila to provide the care na kailangan. But in the long term, hindi naman ito ang last na pandemic na mangyayari. Kailangan din natin i-consider kung kulang ang tao sa government healthcare. Bakit kulang ang tao sa government healthcare? Madami namang may gustong maging doktor. Lack of compensation, hindi sila na-recognize, nababurn out sila, konti yung tao, hindi parang hindi fulfilling sa kanila ang government healthcare kasi wala silang input sa mga nangyayari, sa leadership, sa direction. So, lahat ng, oh my God, bakit ako wala ng signal? Sorry. So lahat ng factors na yun ay kailangan natin i-consider if we want to parang make long-term structural changes sa ating healthcare system. Kasi yun nga, ang UHC natin hindi pa siya nag-lift off the ground. Kakastart pa lang niya, biglang boom, COVID, and yan ang probably the worst thing na gusto mong mangyari sa isang parang health coverage system na kakastart lang na hinahanap pa niya ang kanyang feet. So, maganda, hindi, parang opportunity din ito kung ano yung nakikitang kakulangan ngayon sa ating healthcare system na na-expose dahil sa COVID to address them when moving forward sa future.
Okay, thank you. Meron si Dr. Jillian Pamugas, meron pang last
Okay.
comment.
Sige.
And then, ano?
Doon sa doon sa question, magandang tanong 'yun eh. So parang yun eh, based doon sa data na binigay ba sa PMA, sinasabi nila na almost 84,000 na mga doctors sa Pilipinas, no, yung active na doctors. Out of that, 10,000 yung nag-work sa DOH, no? So pag-isipin mo, nasa mga 70 plus yung mga doctors na nag-work either privately or non-government, no? So yung public health na care system natin, hindi siya nahihiwalay sa iba pang services ng ating government. Halimbawa, sa water, di ba? Ano ba nagko-control? Mas more on private. Sa electricity, anong most likely nagko-control? The private din, no? So, kaya nga, ang naging problem nga, karamihan pa naman sa Pilipino is mahihirap. No? So, saan sila pupunta? Doon sa mga public hospitals na kung saan kulang sa resources, kulang sa human resources, kulang sa equipment, kulang sa funding, parang ganon. So, nakikita natin na mas matindi yung private, hindi sabihin, matinding pagkukulang yung sa public health care system natin na umaangat yung private. Ang problema kasi hindi nasasagot yan hindi siya nasasagot ng government na dapat intindihin niya sa konstitusyon, malaki ang role ng government in terms of yung policy, in terms of yung distribution, in terms of yung control ng healthcare system natin, no? So parang napabayaan kasi example lang naman diyan sa medical schools. Mas marami yung private medical schools compared sa public or government medical school. So pag nakikita mo, most likely ang puntahan diyan private talaga practice kasi hindi mo na-develop pa lang doon sa estudyante pa lang paano nila tinitingnan yung public healthcare system, no? So hopefully nga makita ng ating government yung role niya kung paano niya mo-mold yung future doctors para ma-address yung public healthcare system kasi karamihan sa mga Pilipino is yung mahihirap na walang kakayahan na pumunta sa mga private healthcare, private hospitals kasi nga economically kulang din, no? Kaya pag titingnan mo yung mga data, marami pa rin yung out of pocket, di ba? Marami pa rin gumagastos ng mga Pilipino kasi nga kulang nga doon sa kulang nga yung public health care na funding, kulang yung public health na spending, kulang yung public health ng mga staff, doctors or resources, no? So hopefully sana maayos ng ating government itong yung public health sector, no, in terms of yung pag-address ito sa healthcare system natin.
Okay, salamat. So one last question na lang bago tayo mag-last words from our speakers. So from Advocates for Health, thank you to Dr. Malaya for Santos for giving us hope. We are counting on our future doctors to serve our people given the threats of climate change and pandemics impacting the poorest of the poor. Okay, so wala na tayong questions. Thank you.
Thank you, Den.
Pwede na tayong, thank you, Ren.
Pwede na tayong mag-last words muna mula sa ating mga speakers. And then, before we close, so can we have from Dr. Jillian Lee?
Alright. Talagang last words parang magpapaalam na ako sa mundo. Hindi.
Parang mali
yung
sorry.
Hindi. Ano
Sorry.
lang, closing lang din ang lagi
Conclusions.
kung lagi naming sinasabi is ang health hindi siya nag-exist sa vacuum. Ang concerns ng iyong society, ang social conditions na give rise sa iyong health system and sa iyong pandemic, yun lahat ay kailangan nating i-address when we're moving forward. And if we're going to talk about improve parang yung nararanasan ng ating mga physicians and ng ating mga future physicians pagpasok nila sa healthcare system na ito na hindi encouraging ang pag-serve sa public health dahil nakikita naman natin kung paano tinatrato ang mga public health physicians ng ating government. Nakikita natin na ang mga private na hospitals kadalasan hindi sila nakaka-provide, especially sa mga nasa training programs nila, ng adequate na protection and or compensation. Yung mga factors din na nag-i-influence ng ating mga hospital administrators, ng ating mga local governments, na itrato ang mga doktor natin na ganito, ay kailangan din nating i-address, kailangan din nating i-call out, kailangan din nating i-solve if we want to continue encouraging physicians, medical students to go into public health. So, hindi lang siya dito sa mga nasa community physicians, nasa policy, nasa private practitioners, nasa academe, nasa ating lahat, basically. Thank you. Yun lang.
Thank you, Dr. Jillian. So from Doc Maya, Dr. Santos, can we have
Thank
concluding words?
Nisip ko lang, siguro yung role namin really in the academy is to instill these values into our graduates. And of course, the highest call to service, I don't think anybody can argue with that, is to go where you are needed most, which is the grassroots. And we're so happy na meron na rin kaming mga students na despite na wala naman kaming return service agreement or anything, who have really chosen to respond to the call and go to the grassroots, to the doctors, to the barrios, and the other venues also. But I agree definitely that there has to be systematic support for, doctors to be able to work in the public health sector. And also, I think what we need to realize is that even the specialty societies have a role in things like policy and in creating laws. One good example being the Psychiatric Society that helped with the crafting of the Mental Health Act. And I think that there's a voice also for the specialist and that there's nothing inherently wrong with becoming a specialist. Sana lang yung practice of medicine in the specialty side is also altruistic, is professional, takes into consideration the needs, whether you provide it at the primary, secondary, or tertiary care level. So siguro yun yung nakikita kong role somewhere in the middle of the public health and the private health and the academe and the service sector. Thank you.
Thank you. So Dr. Reg Pamugas.
Okay, so yan, maraming salamat ulit sa pag-imbita sa akin dito. So, yung naman as part ng Compass, so parang hindi naman namin na dito kami para awayin yung government, So, yung part doon sa pag-criticize ng public healthcare system is civic duty naman yan, lahat ng mga Pilipino, para matulungan natin yung bawat isa para umayos yung ating public healthcare system. Kasi yun naman yung gusto natin, So, inaasahan din namin sa government, ito ay yung partnership, pagtutulungan, sa para ayusin. So, ang gusto nga natin mangyari is yung titingnan din niya yung plight ng mga doctors kasi doctor is part ng healthcare system kasi siya din yung nangunguna doon sa pag-address ng healthcare system natin, lalo na itong panahon ng COVID. So, importante na magtulungan, yung ating government at hindi tayo titingnan na parang kalaban agad, pag nagreklamo ka, kalaban ka agad. Kung hindi, nakikita natin yung role ng bawat isa, lalo na sa mga doktor doon sa ating healthcare system, na importante din na maalagaan yung welfare ng mga doctors, pati yung protection niya sa mga kahit anong situation na nangyayari. Kasi tingin ko baka hindi lang to COVID-19 in the next few years, yung mga COVID-22, 23, ganun na siya. So, ngayon pa lang nakikita na natin yung problema ng ating public healthcare system. So, hopefully ma-address din siya sa pagtutulungan kasi ang doctors naman part doon sa stakeholders. dito sa pag-address ng ating public health system. Yeah. So, yun lang po. Maraming salamat din.
So, okay. Maraming salamat sa ating mga naging resource persons sa kanilang contribution dito sa ating webinar and discussion. I hope that we, all the participants and all those who joined, as well as those of us who share their experiences, were able to gain from this exchange and to hopefully help in our efforts for the improvement of our healthcare system and also for the improvement of our of the welfare and the conditions and through which our health workers, especially our doctors, are experiencing right now in the pandemic. As they were saying, ang front lines actually are in the individual families, in each of us, doon sa ating communities, and not only in the hospitals or those in the health facilities. So sana meron tayong mga natutunan from this exchange. Thank you so much to our doctors who participated and shared their time. Hopefully, we will be able to move on and to contribute to our to the objective of our series to raise the bar for our healthcare service in the service of the Filipino people. Thank you very much. So with that, we end our
Thank you, then.
session for this afternoon. Thank you.